When I said before that I think we need to be more courageous as a public health field when it comes to action on the social determinants of health, I think that we would be hard-pressed to find a lot of examples of actions where we directly influenced the policies and legislation that create the conditions in which people can be healthy, and particularly the conditions in which we are creating health gaps. And so TRC, the call to action number 18, called on us to understand the current state of Indigenous health and the Indigenous health gaps compared to the general population as a result of government policy. But since that came out, or when those similar recommendations were made in things like the Royal Commission on Aboriginal Peoples in 1996, I don't think that we saw the examples that we needed to see around things like the racialization of poverty that's experienced by Indigenous peoples, and how appropriation of the lands and disconnection from the lands and resource base, and how other policies that create higher levels of income inequality result in the clustering of Indigenous peoples in the lowest income brackets, and the way that that contributes to the health gap experienced by Indigenous peoples, as one example. If we think about the state of housing, for example, in First Nations communities or in Inuit communities in Nunavut, we have known about the disproportionate rates of respiratory infections like influenza or pneumonia or tuberculosis. We know about the relationship to overcrowded and inadequate housing and food insecurity, but I don't think we have been brave actors in advocating for the type of housing policies that would address this upstream determinant of health. So this is connected to the second part around society's willingness to tolerate health gaps, in that often the reason we don't do this is because we are concerned about the political backlash. And as medical officers of health, we do report and serve at the pleasure of the minister quite often. And so that can create some structural fear around doing this. And if there was more social will, perhaps that would drive more political will, and then maybe we would be able to do our full scope of practice as public health professionals in advocating for these types of changes. And I think, the clearest example that we have of society's general willingness to tolerate these policies and health disparities is the Canadian Human Rights Tribunal decision that said that Canada discriminates against First Nations children with the inequitable funding for First Nations child welfare. And there have been 4 non-compliance rulings since the initial ruling, but there has never been a general public outcry. As a country, we tolerate this human rights violation and discrimination against First Nations children. And I do think there is a role for public health in confronting these discourses and in trying to change them so that we are truly working towards creating equality of opportunity for all children in Canada.